Jesse, thank you. How'd you do that, Jesse? You'll have to tell me. Oh, it's under more. Okay. Okay, let me put it on too. Okay. Okay, well, that's the advantage of being in the main. May record something a little bit. Okay. Let's see. Wanted to do.
Do we need to know the other reflexes besides patellar?
No.
Thank you so much.
Yeah. And I doubt I'll test much, if any. If I test anything on the cranial nerves, it'll be something very obvious, okay? It's not going to be something that we didn't go over very much. I wanted to find the
like obvious, like, so you need to know which does what, but it'll be.
there'll be one that we talked about.
Okay.
Um, okay, well, like I said, this is going to be the next hardest one. Okay. Who's more likely to be colorblind? Males, good. Who is the most likely to have diabetic retinopathy? Which ethnic?
African American.
Hispanic.
Oh, his.
Hispanic, yeah. Who's most likely to have macular degeneration?
Short, white female.
That's right. I think I feel discriminated against.
Well, what disease was that one?
Short white females are more likely to have macular degeneration. I think I'm being singled out
I
there.
wonder why that is.
You know, I don't know. Also,
What about being taller
yeah.
keeps you? It's funny how some disease processes are specific to a.
Do you think maybe it's on the same gene as whatever gene, you know? I don't know. Makes you short? That's a good
Probably.
question.
Yeah. Now my whole family's going to have macular degeneration.
Also, we're at risk for, you know, for gallbladder disease, you know.
Yeah.
Who's most likely to get cataracts?
Someone that works outside?
Yes. Let me tell you, I was just in Florida over spring break. I have never seen so many eye doctors. They're over there, you know, there's a lot of old people there, but I think all these surgery centers, they take cataracts out all day, every day. Remove cataracts. Let me let Brittany in. Okay. Who's at risk for glaucoma?
African Americans.
No. Also, which disease people with which disease processes are at risk for glaucoma? There's a bunch of them. Diabetes is one. Hypertension. If they've had what kind of problem with their retina? A detached retina are at risk. If they're severely, what? One of the refractive errors I'm thinking of. Myopia. Yeah. So I would look at, our risk factors that could pop up. Which of these ophthalmologist, optometrist, or optician is actually a medical doctor or a doctor of osteopathic medicine? An ophthalmologist. And they are the only ones who can what?
Do surgery.
Right. Can an optometrist also, specialize in some of the diseases of the eye?
Yeah.
Yeah, and diagnose it and treat it. But the only one who's a true MD or DO is an ophthalmologist. And what do opticians do?
Eye exams.
Yeah, they can dispense optical appliances, fit eyeglasses, lenses, and frames, contact lenses. And the Isahara color test determines what?
Color blindness, depth perception.
Yes. I would be familiar with these diagnostic studies, okay? CT, CTs,
OCT.
MRIs. Like MRI is for soft tissue, to examine soft tissue, whereas CT, you can look at the blood vessels, muscles, optic nerve, that kind of thing. Ultrasound, they can look at diagnose cataracts, retinal detachment, radioisotope scanning. They can diagnose tumors, malignancies, melanomas, ocular melanomas, stuff like that. Just the basics of what you would kind of disease processes you would use for each of those. What about a slit lamp? What's that diagnosed typically?
Abrasions.
Corneal abrasions. And what do they usually put in the eye prior? That, yeah. Exactly. And this is a picture of what? What do they see?
The vein.
Yeah, you can see, macula, retina. And to measure visual acuity is what? What do you use that? The Snellen eye chart. And what's the most common eye disease? And what are the three types?
Viral, bacterial, and allergic.
Okay. Which one's most common in children? Because they are nasty. They are cute, but they are nasty. And they're always rubbing their eyes. They're touching everything, rubbing their eyes. Can conjunctivitis just be in one eye, or does it usually both? It can be in one eye. If it's allergic, though, you think it'd be more common to be in both eyes or one eye? Yeah. whereas bacterial can be in one eye, but it can spread to the other one. Which is most common in adults? Which type? Yes. And do you always have to have antibiotics for, does it always have to be treated?
Which one's
Conjunctivitis?
in adults? I'm sorry, I couldn't hear.
That's okay, Emily. Which one can you all tell her?
Viral.
Viral is most commonly in adults. What's the best way to prevent conjunctivitis? Hand washing, good hygiene, avoid touching your eyes. 65% of cases resolve without treatment within 2 to 5 days. Even bacterial will usually resolve without treatment. I don't know if I agree with this. It is so painful. But if no improvement after 3 days, you may need topical antibiotic. What can you tell me about the symptoms of a retinal tear, hole, or detachment? What will they typically see?
Your eye, you get floaters. What else?
Floaters, flashes of light,
Yeah, that,
like,
like the curtain, like vision. Where they have like the curtain, like a curtain or screen
Yeah.
down over your eye.
and it can be diagnosed how? You usually see it with just ophthalmic examination, the ophthalmoscope. Why won't this leaf go away? Okay. And what is treatment? How do you treat a retinal detachment?
That's what I thought.
They can use the cryopexy or laser to kind of tack it scars, creates a scar that binds the retina and the choroid together around the break. What's your main nursing interventions for somebody who's undergoing something like this? They're going to be sticking laser in my eye. How am I going to feel as a patient?
Anxious.
Very
Decreasing
anxious.
cranial pressure.
Yeah, you don't want to do that. But, one of the big things is, providing information and reassurance to the patient. And you're right. Who said that about not increasing, restricting activities and head movement? You teach them that. An eye patch to the affected eye to reduce eye movement. May teach them how to use topical drugs to inhibit pupil constriction and accommodation, because you don't want that after they've had their retina reattached, right? What kind of anesthesia? General anesthesia. And if gas or silicone is placed inside the eye to promote retinal attachment, what happens? These agents what? They kind of float up against the retina to hold it in place and promote healing. What's our postoperative care? We always do this. We always monitor vital signs and check their patch or shield for drainage. If they have that gas or oil, what do we teach them?
To keep their head still.
Yeah, whatever position the surgeon says, we're going to teach them to stay that way. Right, very good, Ashton. Avoid activities that increase intraocular pressure. Would it be a good idea if they just stay quiet and read a book? They can't do that. No reading, no writing, no close work like sewing. What should they report immediately?
Inability to move their eye or sudden vision loss. Or pain. Any signs of infection.
They have increasing pain. if they have sudden reduced visual acuity, if they notice or somebody notices that their pupil does not constrict to light, those are all warning signs, right? Be infection, or it's becoming the detachment, it's becoming detached again. So got to know that right away. I would know all those, okay? Tell me what's important to know about macular degeneration.
There's two types, wet and dry. But, dry is the more common one.
That's right. Dry is the most common form. One is a gradual blockage in the retinal capillary arteries, resulting in the macula becoming ischemic and necrotic. Which one is that?
The dry.
The dry. And that does make sense, because the other one is caused by new growth of blood vessels that have weak walls and leak. And that's the wet, or less common form, right? Picture there. Who's at risk for dry macular?
People who smoke, hypertension, females.
Short females, short white females. Or if they have a family history, or if they have a diet lacking in carotene and vitamin E. If somebody asks you what they could do to improve their chances of not getting macular degeneration, and they're asking about nutrition, what could you tell them?
Vitamin E.
Huh?
Vitamin E.
Mm-hmm. And they could do that how? Anybody know any foods that have vitamin E in them?
I always want to say salmon.
Avocados.
What's that?
Avocados.
I think so. I want to make sure I don't tell you the wrong thing, so I'm looking it up. Almonds, peanut butter, beets, greens, collard greens, spinach. So, Lupe, very good. Pumpkin, red bell peppers, things like that. Avocado. Did somebody say avocados? Apricot.
Yeah.
Okay. Or they could take what? A-reds, vitamins. Yeah. Good. And what do people notice who have in their vision typically if they have macular degeneration? This actually, the central vision is affected, right?
Yeah.
What is the one though that is tunnel vision? Can you? Glaucoma. Very good. So know which eye disease produces what type of vision for the client, okay? Other symptoms of macular degeneration include problems with depth perception. Objects may be distorted, blurred. Loss of central vision is the biggie. And what is, ultimately they could become totally blind, right? And is that correctable after that happens? No. So diagnostics, slit lamp, ophthalmoscope, visual acuity tests, and such as the Snellen. We didn't talk much about the Rosenbaum, so I probably won't mention it either. But what is that Amsler grid? Do you remember that one? That's really specific for your macular degeneration. It's the grid, looks like graph paper, but in somebody who has macular degeneration, what does it look like? It's kind of, yeah, kind of like scrunched up in the middle kind of thing. Good. And there's a picture of that. That's normal versus AMD. It kind of looks like a screen that has a defect in it, right? Okay. How do they fix the wet AMD? The one where the leaky blood vessels, what do they do?
Shot.
Injections with an endothelial growth factor inhibitor such as bevacizumab. Or sometimes they can use lasers to seal the leaky blood vessels. And there's no real cure, but we try to do what we can so that they get worse more. What? Goal is to get worse more slowly. Good, good. Teach them to eat what? Foods high in antioxidants, keratin, vitamins E and B12. Maybe take those supplements. What do you kind of prepare them for? Yeah. I mean, many of them will eventually have trouble eating. Driving is a tough one for a lot of them to give up, as you can imagine. Reading, writing, and other activities of daily living. And so what do we do to kind of help people prepare for this kind of stuff? What kind of things can we do to help them if they've lost the ability to do with some of these things?
To like different organizations.
Referrals, community organizations, exactly. For transportation, they have reading devices, large print. It's kind of limited usefulness, I guess, because if they can't see. All right, tell me about cataracts in a nutshell. What is a cataract? The lens becomes what? Or opaque, cloudy or opaque. Cloudy lens, yes, Devin and Jesse, thank you. Can it occur in one eye? One eye or both eyes? It's the most common surgical procedure in the United States. Like I said, remember this, there was an eye surgery place, now almost right next to each other in Florida for all us old people. All right. Causes of cataracts. Let me let Chance in. It's basically, it can be age related. A lot of it is age related, and that's just the drying of the lens. You kind of shrivel up as you get a little bit older, lose that water, Traumatic cataracts are caused by what? Could be a blunt or penetrating injury, or some foreign body in the eye, or exposure to radiation or ultraviolet light. Toxic. What's toxic cataracts? What are those due to? Chemicals such as chemotherapies or long-term corticosteroids. Thank you, Jesse. Beta blockers. Did you know beta blockers like metoprolol and all that can cause you to have cataracts? There was there's this kind of allergy medication that they give to dogs, Apoquel, I think it is. And it can cause cataracts in dogs. I don't know if humans take Apoquel. But, there's a lot of medications that can cause cataracts. There's another medication, though, that's much more expensive and doesn't cause cataracts in dogs. And Martini gets that one. Can't remember what it's called now because nothing is too good for Martini.
The reviews, like,
Mhm.
Martini's upset because
You gotta go.
bad.
What is an associated? What's associated cataracts? You can think of this like associated with something else, such as diabetes or hypoparathyroidism, Down syndrome, or chronic sunlight exposure. It's a secondary diagnosis. That's correct. And complicated, so it occurs in conjunction with something like some other intraocular disease like retinitis pigmentosa, glaucoma, or retinal detachment. It's kind of a shade of gray between associated and complicated. So we just have, Okay, what kind of vision problems do people with cataracts typically have?
More yellowy. Yellow.
They have yellowing vision. Remember we talked about the painters, the famous painters who later in life would get cataracts and their paintings changed. They were more yellow. The colors weren't as vibrant. Like Monet did the blues and greens. He's famous for that. But when he got cataracts in that era, you could see that most of the colors were yellow. What else will they complain of, these people with cataracts? I'll tell you, you'll say, well, the party starts at 8, and they'll say, well, I can't come because what?
I can't at night.
Because it's dark. And yes, Jesse, they can't see as well at night. They can't drive at night, they say. Also glare and halo around light sources. Lots of night vision. Good. Okay. Assessment, we've got our, risk factors, getting older, having diabetes or some of those other diseases. They can be hereditary, they can be secondary to smoking, any trauma to the eye, excessive sun exposure, or use of certain medications such as corticosteroids. And we talked about the expected findings, which in addition to, decreased visual acuity, people may need more frequent prescription changes to their eyeglasses. We said reduced night vision, decreased color perception, blurred vision. But did we also say double vision?
Yeah.
That can happen. It can also lead to progressive and painless loss of vision, visible opacity in the eye, and absent red reflex. You know what the red reflex is in the eye? Like when you take pictures of some people and you'll see that red. That would be the hardest thing to pick up on for. I don't even know how you test for red reflex. That's something probably like the ophthalmologist would do. So the big thing is to teach people to what? To prevent, to wear their sunglasses when outside, protective eyewear because going back to the traumatic type that you can get, and encourage annual eye exams, especially over the age of 40. Okay, tell me about the surgical options for cataracts. What's a, can anybody say this? This F or PHACO? I think it's phacoemulsification. Is that, which one's the most common form? This is where they do what? They put, it's ultrasonic vibrations that dissolve the lens into fragments and then they can just suction it out. Do they need sutures for this?
No.
That's the one without sutures, right? Which one breaks up? Very good. Which surgery is most common? Cataract. The phacoemulsification. There's also regular surgical therapy, and it's used most typically for what? Advanced cataracts. And in this, the entire cataract is removed, it's whole, but they also, which one recovers faster? Yeah. Sutures are usually required with surgical therapy, and then the recovery is usually slower. Remember I told you when I first got out of school, I had some patients, they'd stay with me for 3 days after cataract surgery. Okay. In the post-operative phase, you know, it's typically outpatient now. They'll get typically an antibiotic and a corticosteroid eye drop. You're going to teach them to limit what activities? That would increase what?
Eye movement, up close reading,
Say that again, Kevin.
uh,
Increased pressure, intraocular pressure, yeah. You're going to be concerned also about what after surgery? Any surgery, but this surgery too. Preventing what? Infection. Julia, yes, nausea and vomiting. You don't want any of that because that would, if they vomit, they're going to increase their, yes, pressure. You're going to teach them, you know, they may have some pain. Devin, it's more intraocular pressure you're worried about than intracranial, but yes. You're going to teach about how to take care of themselves. What are they going to report? What do you want them to report if they have what? What are you going to be? Because we've already said, you know, we're worried about infection. So what does that look like in somebody who's had a cataract removed?
Yellow, green, drainage. Reduced visual air.
Acuity.
Mm-hmm.
Increase, yeah. If they suddenly become very sensitive to light, if they have increased tear production, they need to call you because they could be having what? Infection. If they have any sudden change in their visual acuity or an increase of pain, that's an immediate phone call. Okay. Can they tilt their head back and wash their hair if somebody else does it?
No.
No. Can they make dinner when they go home? Can they resume their housekeeping and vacuuming and cooking?
No.
Can they drive?
No.
No. Can they play sports? No. They've got to report any, you know, especially pain with nausea, vomiting, because that could be increased intraocular pressure or hemorrhage. Okay. When does the best vision? When can they expect the best vision? They call you, you're the triage nurse, they call you and they say, you know, I had this surgery the other day and
like
I'm
4
still not seeing very good.
4 to 6 weeks.
Yeah, tell them hang on.
Yeah. Yeah.
Okay, do y'all want to take a quick bathroom break? Take a 5 minute?
Mhm.
5, 10 minutes. How's your baby?
She's good. She got a little cold.
Okay, so Erica asked a very good question about how long do you limit the activities after um, eye surgeries. It's up to the surgeon and his or her preferences, but usually you can resume like light activity like reading and close work and cooking and all that kind of stuff within a week or so. But strenuous activity like playing sports or anything that would really increase intraocular pressure, like bending over, wearing tight clothing, lifting weights or any of that is for several weeks after surgery. But I probably won't test over that because that can vary. All that can vary depending on the surgeon's preferences. Okay, let's talk about glaucoma. So the expected reference range for intraocular pressure, what Morgan is what? I would know that.
What was the question?
What's the expected range for
Oh.
intraocular pressure?
10 to 21.
Right. And so Typically, with glaucoma, you would see intraocular pressure of what? Greater than.
30 or 21.
Mhm. And what is the major malfunction with glaucoma? What's going on? What's the pathophys? In a nutshell.
Too much pressure.
Yeah,
There's like
due
either
to,
too much secretion. I mean, yeah, it's either secreting too much fluid or it's not draining enough.
right. You've got problems with either overproduction of fluid or you've got a problem with the ability to drain it effectively, fast enough. And so the end result is increased pressure. Can it cause blindness? In fact, it's the second leading cause of blindness. What is the key to preventing this blindness? Catching it in time, treating it if it is present. And you can have primary glaucoma, which is the person just has glaucoma, or you can have secondary glaucoma due to what?
Trauma.
Ventroretinal vein occlusion, uveitis, iritis. Neovascular, what does that mean? Neovascular disorders. Those are usually malignant, I think. Neovascular means new blood vessels. Remember we talked about that in the AMD. So yeah, problems people have neovascular, have these blood vessels, abnormal blood vessels for whatever reason that can also lead to glaucoma.
Is that one my cardiologist always looks at?
Could be, yeah,
Does a very good exam on that.
yeah,
Just about every time that
right. Ask him why he does that next time we have him. And so what does the patient experience who has glaucoma? What kind of vision?
Tunnel vision.
Like a tunnel vision, that's right. So, we've got normal vision, early glaucoma, you see the shading and then it becomes a little worse, very binocular, and then extreme. And then can that progress to blindness? Yeah. It is the leading cause of blindness in African Americans. Unfortunately, many are unaware. Incidence increases with what?
age.
Age. It is totally preventable and it also has a genetic component. So what is the deal with primary open angle glaucoma? What's the main problem? This is the most common type and it's result of what issue? We said it's either overproduction, decrease,
Production.
it doesn't drain. It's not draining. And primary open angle. You got bad drainage. Thank you.
That's the primary one.
Yeah, primary angle closure caused by age. I really wish that this would go away. Could also be due to infection, tumors, diabetes, genetics, hypertension, trauma, myopia, and retinal detachment. A lot of these have the same risk factors. Are you picking up on that? So you want to encourage annual eye exams, especially after 40. and teach patients about the disease process, early indications of glaucoma. And what are these early indications of glaucoma? These are important, okay?
Reduced vision and now eye pain.
Yes. They're kind of vague, you know, but there they are, okay? Okay. And can you describe the drainage system of the eye? The trabecular meshwork drains aqueous humor via the Schlemm's canal into the scleral plexus and general circulation. So it's that trabecular meshwork that drains the fluid in through the Schlemm's canal into the general circulation. Okay. What is the treatment for chronic open angle glaucoma? Medications are usually the first line, right? And remember we were talking about the trabeculoplasty or the trabecular meshwork. That's why I wanted you to know that, because of what would the laser trabeculoplasty, do you imagine? That would increase, that would open up that trabecular meshwork, or a trabeculectomy, or drainage implants with, that's usually with secondary or pediatric glaucoma. So you got to fix one of the two problems. You either got to give them something that they won't produce as much fluid, or you got to do a procedure typically to increase the drainage. Does that make sense? All right. I would know, you know, primary angle closure glaucoma, okay? An acute episode of angle closure glaucoma is what? This is when the angle between the iris and the sclera suddenly closes, causing a corresponding and sudden increase in intraocular. It is a medical emergency. That's exactly right. I know that one. What do you see as the major difference between the expected findings of primary open angle glaucoma and primary angle closure glaucoma?
Angle closure one has pain with it.
Severe pain and nausea, photophobia, a rapid onset of elevated intraocular pressure like 30 or higher. What did we say the normal was? 10 to 21, so 30 is pretty high. That's good. I would know those, you know. It's a little less in the primary open angle. It's like 22 to 32, right? But much higher in the angle closure. Okay. What is the big one that they use to diagnose glaucoma? They do a visual assessment, but they also do that thing. What's that thing where they puff the eye, puff the air into the eye? What's that called? Tonometry. And what are they doing? What are they measuring with tonometry? Pressure, exactly. And gonioscopy, they're looking at the drainage angle, seeing how things are draining, right? Okay. What are the primary intervention for treating glaucoma is what?
Medication.
medications, and it's usually given in what form? Beta blockers. It's usually an eye drop, right?
Yeah.
And it's usually every or twice daily. How many hours apart? 12 hours. Can they give it at like 8 and 5? Just because that's, that's when they eat their breakfast and their dinner, just so they can help remember it.
No.
Would that be okay? No. Every 12 hours. How long should they wait between eye drops if more than one medication is prescribed? Yeah. And what should they do before they put the drops in? And what should they do once they instill the drop?
Press in there.
Punctal pressure, yeah.
Going circular
Punctal occlusion. Yeah.
in your circulation.
And why wouldn't you want to go into their circulation?
Or, beta blockers.
It could cause
Overdose or.
Hypertension.
Hypertension.
Yeah. hypotension.
Yes.
Okay. Beta blockers are the first line, right? Also, they should be used with caution in patients who have, because they can cause what? Very good. Or they can potentiate the systemic effects of oral beta blockers, cause bradycardia and hypotension, as Leslie pointed out. Okay, then the other ones are like cholinergic agents. They constrict the pupil, right? And what kind of things do they cause? What kind of symptoms or signs? Blurred vision. Pilocarpine is a good second line drug for primary open angle. But it causes blurred vision, so what are you going to teach your patient?
Use good lighting.
Mm-hmm. You need to worry about falls, right?
Mm-hmm.
Okay. And then there's adrenergic agonists, and those reduce intraocular pressure by limiting production of the aqueous humor. You want to dilate the pupils it also dilates the pupils to improve fluid flow to the site of absorption. And you would teach patients who are taking this to do what?
Or sunglasses.
Yeah. Okay.
Are there gonna be specific questions about, like, all of the glaucoma meds?
I expect there may be one about beta blockers.
Okay, but not like the,
No.
okay, I was like, they're kind of a lot.
I know it is a bit much, isn't
Yeah.
it? But what I want you to know, though, is that all these different medications do have their own, their own side effects. And they, whenever you're given to them, I want you to remember to look at them and teach your patient what they need to do. Okay?
So know the side effects or know the teaching for each medication is what you.
Well, if you know the side effects, you kind of know the teaching, don't you? If it's going to cause blurry vision, you're going to teach about, being careful about falls, not driving, those kinds of things. Okay.
Yeah.
Surgery, we already kind of talked about this, right? Okay. The trabeculectomy, replacement of shunt to improve drainage, and what they would need to do to not increase intraocular pressure. And who would do this surgery? We send them to an optometrist, ophthalmologist, right? If they are, if they are likely to have severe impairment to their eyes, we'd want to make appropriate referrals, outreach programs, Meals on Wheels, services for the blind. They need to have regular glaucoma checks after age what? Especially after age 40. I wouldn't be so picky as to say the client is 55 years old and ask how often, I'm not going to do that. Okay. Eye trauma. Somebody had a question about this. If there's a contusion, which is a fancy word for what? What do you do for that? You apply.
I,
And should a client go see a physician
or eye doctor.
or an ophthalmologist to have a thorough eye examination and rule out presence of other eye injuries? If there's a laceration due to a penetrating injury and there's an object in the eye, what do you do?
You never remove it.
You never remove it. And should you apply an eye patch?
No.
Probably not. Should you irrigate it?
No.
No. You leave it alone. You tell them not to touch it. You don't put an eye patch on it because it may disrupt the foreign body and cause further issues, right? Okay, corneal abrasion. What is this?
Right. For the cornea.
Cornea, scratch or scrape to the cornea. Is it painful?
Mhm.
Horribly painful. What are complications, potential complications? It can
Have-
become what?
Infected.
Infected by bacteria, protozoa, or fungus. A corneal ulceration is a medical,
Emergency.
and this is a deeper injury, deeper than an abrasion. And why is the cornea especially susceptible to difficulty healing or infection?
Alternate blood.
It has a poor blood supply, and there is no alternate. So if it's infected, how good is an antibiotic going to be if there's not much of a blood supply, right? So you got to be very careful with these. And the symptoms are what? Of a corneal, very painful,
Light sensitivity.
very much light sensitivity, very blurred vision, eye secretions, cloudy or purulent fluid on the eyelids or lashes, and then they are what? If there's purulent, what does purulent mean? Pussy, yeah. So that indicates what? That's right. This is a lot of times if they suspect a corneal abrasion, laceration, they'll put in the fluorescein stain, look at it under what kind of diagnostic thing? What do they use?
Fluorescent.
What kind of equipment will they use to examine?
Oh.
The slit lamp, yes. I want you to think of those together. Good, Devin, slit lamp. Keratoconus is a degeneration of the corneal tissue resulting in an abnormal corneal shape. You see that little bulge there? It can be due to a trauma or inherited disorder. Okay. Auditory stuff, let's see. You already know the structures and function. We typically examine the ear using a and what kind of equipment do they use to do the Rene and Weber test? The tuning fork. Okay. And Which one, the Weber test is for what kind of, to test for what kind of deafness?
What'd you say? I'm sorry.
The Weber test is for what kind of deafness? You got two choices, conduction or sensory conduction. Very good. And if someone has conduction deafness, the sound is heard better on what side? The affected side, or the side that is they're deaf in. While in nerve deafness, the sound is heard most loudly in the unaffected ear, which is interesting, right? Okay. If I was going to tell you your patient's going for tympanometry, what would you expect they were going to examine? The eardrum, yeah. The middle ear. They're going to look for fluid in the middle ear, or otosclerosis, or an infection, or perhaps a what? Perforation. Anything to do with yeah. Good job, Erica. Sorry, the other Erica. Leestown Erica.
Okay.
What might they use? Why might they do an electronystagmography? ENG.
Going to that central and peripheral disease and the vestibular.
The vestibular system, good. So if somebody was having what kind of difficulty might get this, the ENG? Patient with nystagmus, certainly, or vertigo. And then you know about the, CT, they're looking to visualize the structures of the ear. MRI, a lot of soft tissue, doesn't show bone, I don't think as much, but it's more detailed. Which one is more expensive, do you think? CT or MRI? MRI. It's a lot, and it takes a lot longer. What else? It's that beating. What would you tell your? Yeah, there's very thin slices. There's 100. Yeah, there's so many frames that they take. Okay. What's external otitis? What's the common name for that? Swimmer's ear. That's right. And who's affected mostly? Kids. And what would you expect to see, and what would your patient complain of?
Tender touch.
Yeah, your
Pain,
cues.
movement.
Yeah. If you kind of jerked on their ear, what would they do? Probably hop off the table. They may start crying. If you looked in the ear canal, what are you going to see? External otitis, swimmer's ear. What color? What color is the ear
Redness.
canal going to be?
Red.
Going to be red and irritated. There may be some clear drainage. There may be water drainage because it's from, a lot of times it's from infectious organisms that people get while they're swimming, right, in the ear. What is the big nursing diagnosis associated with this one? Pain and infection. Pain and infection. And what are the typical treatments? Pain, infection, inflammation. So let's think through it. What kind of treatments?
Probiotic.
Antibiotic. Eardrops. What are we going to give them for pain? Ibuprofen or Tylenol typically. What if it's a fungal? If we suspect it's because of a fungal infection, what kind of medications? Huh? Lotrimin? Mm-hmm. Probably in an eardrum. Whereas, okay, so we have the external, what about the internal? The middle ear infection. What are we going to see when we look at it with a scope typically? There's an infection brewing behind the eardrum. So what's that look like?
So it was like pink and yellow and red, sometimes bulging,
Yeah, a redness, bulging, tympanic membrane. May not be able to see the landmarks because of the fluid, the infected fluid behind there. What are the signs and symptoms? What are the cues? What are patients going to tell you?
pain, pressure, fever, ear loss,
What kind of hearing loss typically?
conductive.
What's the difference between conductive and sensory neural hearing loss? Conductive is usually because there's something
Blocking it.
in the ear.
And the sensory is more something to do with the nerve.
There's nerve damage somewhere. That's important too. Okay. And if a patient has a terrible pain in their ear and it suddenly goes away, what do you think has happened? It's perfed. They have a tremendous sense of relief. How do we manage a middle ear infection?
Usually oral antibiotics.
And heat can be very helpful. Sometimes it can happen because of allergies too. Allergies can make it worse. So what could they give? Antihistamines, application of pain or heat can be very soothing. And what is a potential complication of middle ear infection if it is untreated? Mastoiditis.
What was that you said that if the pain just suddenly stops?
It usually means their eardrum is perforated, especially if it's accompanied by fluid, like with kids, a lot of times they'll wake up and you'll see all this pussy drainage on their pillow. And what is a myringotomy? Yeah. Equalizes the pressure. What is tinnitus? Ringing in the ears. And it can be caused by medications. There's more than 200 drugs that cause tinnitus. Also, people who are exposed to high levels of noise, it can be the first symptom of hearing loss. So should that be investigated, or would you just wait and see?
Investigate it.
Okay. I would know the typical culprits for medications that cause tinnitus, especially those first three, probably. Can also be caused, of course, everything goes to pot when you get older, right? Age is always a good guess, any injury to the ear, certain circulatory system disorders. So if somebody has, vascular disease, they may have tinnitus. Also, let's see, impacted earwax, vascular circulation disorders, hearing loss, noise level exposure, Meniere's, tumors, neoplasms, so damage to cranial nerve 8. But what's the most common cause of bilateral hearing loss in young adults?
Trauma?
Otosclerosis. And do you know what Schwartz's sign is? The reddish blue blush of the eardrum, or and this is treated with medications that slow bone resorption, hearing aids, and surgery. I know a little something about hearing loss, like the early signs typically go unnoticed. Usually it's pressure by others in the patient's life that bring them for help. Always obtain interpreter assistance if you have somebody who has hearing loss, deafness. Don't rely on the patient's family, for example, to be an interpreter. And when you're teaching something, how you should be especially careful to what? Validate whether they actually wanted it. But there is also, it can be gradual or sudden. A lot of times people come in with just one ear affected. This is always in a medical emergency. Know the difference between conductive and sensory neural hearing loss. Okay, let's go back here. Which one, conductive or sensory neural, does the patient typically hear better in noisy environments? Conductive. For sensory neural, hearing loss results in inability to hear sound, they can hear sound, but they can't understand speech well. And hearing aids aren't necessarily helpful because why?
They make it louder, but
Not clear. Here's some signs or reasons for hearing loss, sensory neural hearing loss. Meniere's disease, and in addition to the usual culprit. Also, drugs. Do you know all these ototoxic drugs? Aspirin, NSAIDs, antibiotics. What kind of diuretics? And chemotherapy drugs. In conductive hearing loss, what do those patients typically do? Do they speak loud? They'll speak softly. And the best thing you can do is identify and treat the cause. Hearing aids are better for people with this type of hearing loss. Here's a good picture of a perforated tympanic membrane, okay? People can also have mixed loss, central and functional hearing loss. I probably won't test over these. Just know conductive and sensory neural. Okay. And what is the best thing you can do in terms of health promotion? The most preventable cause of hearing loss is what?
noise.
Yeah. Is hearing loss caused by noise? Is that reversible? And we talked about noise, other toxic substances. What about industrial chemicals? Can those cause deafness? Yeah, there are several that can cause deafness. So if you were gonna be assessing your patient, interviewing your patient, what kinds of questions would you want to ask them? If you
Mercury or,
type of work,
yeah.
what kind of medications they take, do they wear earphones? Do they play their music loud? Of course, that's a subjective thing, isn't it? No, I don't play it loud. You can hear it from across the room. Do they ever if somebody does have some kind of hearing loss, what's important? Can you just say, okay, well, it's pretty bad, see you in a year? Probably have to follow up pretty frequently, right?
Yeah.
And remember I told you that discontinuing drugs, like even chemotherapies, they'll sometimes change them or stop them because of your hearing loss. Okay, so discontinuing a drug may be necessary. You know about, I would know a little something about the hearing aids and things like that. You know, like they have to be fit by a specialist. Although they do, I think you can get them at Costco now, certain kinds. They're better for people who have what kind of hearing loss? Right. You know, is this you know, kind of get your hearing aid and everything should be okay? Or does the patient have to be what? Pretty motivated and pretty capable. They have to be able to change the batteries or somebody has to, right? And be able to, you know, a lot of times they just don't want to lose them. They keep them in a drawer. Who's that helping? Probably not the drawer, right? Okay. What are some other assistive devices and techniques?
Speech reading.
Lip reading, visual cues. So for the nurse, what's conductive hearing loss, right? As Asha wants to know. So if you're interacting with a patient who is hard of hearing, and you come into the room and you have some information, discharge information, tell me what you're going to do to that room, or make sure, like,
It's
where are you going to
quiet.
sit? It's quiet
Sit directly in front of them so they can look at your lips.
at their level.
At their
If you're
level.
sitting, I'm sitting, right? What else? Sometimes glare, you know,
Yeah.
make sure that there's not a big glare in the room, that they can see your face. Any of you playing at home have any idea about how to improve communication with somebody who's hard of hearing? You have to do teaching. Decrease stimulation, turn the lights on or up, avoid glare, so to face the patient. If you know sign language, I took 2 semesters and I have absolutely no recollection of it almost. I took it as an elective. But if you know sign language, that's good. Is sign language universal though? What's American Sign Language? That's used where?
In the United States.
In the English speaking areas of Canada. I don't know what they use in the French. But that's, you know, it's for people with profound impairment. They have the implantable ear hearing aids, partially implantable, has an external component, cochlear implants. I'm not going to ask about those. But one thing I might ask about, what is the texting system or alerting systems? I want you to just be aware of those. That, you know, I had a patient and I would call, how did this work? They had a special phone and somebody would come on that was a sign language interpreter, and they could see the sign language as I was talking in real time. So that was good. I just want you to know that those are available. And there's texting systems. It's a lot easier now that everybody has a cell phone. You can text people. closed captioning, there's specially trained dogs. So know your resources is the, okay, now finally we're going to talk about vertigo. What is the source? What's the main malfunction with vertigo? When is it?
Changing position.
Yeah, it's usually triggered by a change in position, and it's thought to be, due to, like, they call them crystals, I think, or debris that's in the semicircular canals in the ear. It typically has a sudden onset, can last days to years. It's usually remedied with what? With bed rest and meclizine. My mom has this, and it'll come on like that. She'll be so sick. Although this says that they don't typically have nausea and vomiting, so I forget I said that, but my mother does. I will tell you. Meniere's. What's the difference between that and Meniere's in terms of it's accompanied by, there's vertigo, but there's also what?
Ringing in the ears.
And it can also be accompanied by
Hearing loss.
hearing loss. That is a major difference. Labyrinthitis is due to what?
Inflammation.
Inflammation of the labyrinth in the inner ear. It often occurs secondary to what? No. I mean, it can cause vertigo.
Media.
Yeah, otitis media, which is what, a fancy term for middle ear infection. Very good. It can be accompanied by nausea and vomiting, tinnitus, and possible hearing loss. What is our treatment for that?
Bed rest in a dark room. Antibiotics and
Meclizine is what kind of drug?
Isn't that antihistamine?
No. It helps the vertigo. Oh, it is an antihistamine. I apologize. So it is an antihistamine. It helps with the vertigo. Diamond hydrogenate is also an antihistamine. Why would they give systemic antibiotics? If they think it's being caused by inner ear infection. So not everybody would get systemic antibiotics, but possibly. I already talked about that. Okay. What's presbycusis, though? Who gets presbycusis? Think about what's presbyopia. Is there anybody in here over 40? When you were 40,
Oh, like that when you gotta start wearing your reading glasses.
Yes.
You can't see anything here anymore.
yes, when you think of anything, it's usually age-related, okay? So presbycusis is hearing loss associated with aging. Okay.
You're like, ew, here.
40. Okay, so does anybody, these are the most difficult, we covered the material that is the most difficult. The other stuff is fluff that you should be able to go over your PowerPoints. Like I would know what the difference is between a healthcare surrogate and a POA, and just hit the highlights on that stuff. This is that stuff you've been told before. That's not new material, right? Um, this is the tough stuff. This is, if you, master this, you'll be fine on the other stuff. The other questions, there's going to be there's going to be maybe one or two on that psychological safety thing. And there's going to be some,
Is that the where it says the,
What PowerPoint is that one? Psychological safety?
human flourishing one?
Yeah.
I was trying to find it on there.
Pretty sure it's on there. Remember, this was like a 12 slide.
Oh, is this?
Slide with not a voiceover.
Oh,
I was right, I did.
Is that the slide with the, oh, because the human flourishing was
Oh,
the video.
Human flourishing is difficult, or not difficult, it's different.
Okay. There's a whole PowerPoint about.
This psychological safety, that was the assignment, that UPSLO assignment we did.
Oh, that one.
Yeah.
Okay. What did you say was on the human flourishing one? You said something was on,
There'll be some questions on that.
oh, I thought you said psycho safety, human flourishing.
Well, that's what I want to make sure you understood, that the human flourishing PowerPoint, I would look at that, but I would also look at this psychological safety one that we did. Okay, there might be a question or two included under the heading of human flourishing on your exam one blueprint, okay? Um, okay, so that was just a few slides, so that should just take a minute to kind of review that. All right, does anybody have any questions? If you do, you can email me. And, some of these, the delegation and prioritization assignments, it'll be a little scenario, and then
Would that be for the clinical judgment
mhm,
question?
mhm. But, those are nothing to be nervous about, because you all do very well in those, okay? All right, so I think,
The
We
math
hit the-
questions, should we look at like ID stuff, like what type of math questions? should we-
I would know how to calculate rate. Thank you for asking this question.
Like,
IB rate, what is the formula for calculating rate? And I probably won't give you anything on the drip factor. It'll probably be on a pop. What is our formula? Rate equals,
Over,
time's in there, but it's not what is the numerator or the
volume over time.
volume over time? And so if I tell you that there's 200 milligrams in 100 milliliters, if that's the concentration, what number are you going to plug into that formula? Which one is volume, 200 milligrams or 100 milliliters? Very good. You're more, because your answer will be in milliliters per hour. I'll give you a rate, and the other one will be different. I don't know. But I'll tell you that there's going to be a rate one. Okay, have a good night. Okay, so you guys should be in good shape.
For the nurse informatics, is there anything we should focus on?
The nursing informatics. That was also pretty short. I would know the roles. Maybe be able to identify the benefits. Maybe be able to identify key components like the electronic health record. You know, like the nurse knows that the components of nursing informatics include, maybe it'll be a select all that apply, something like that. I think any questions in this area will be pretty straightforward, okay? But we did a major, deep dive on the meat of the exam. I'm not going to try to trick you or anything, but be familiar with the content of the other stuff. And think about it before you answer. By this time, you guys are pretty good at taking these types of tests, You don't pick the first answer that kind of looks right anymore, So I have a feeling. And most of you read all the answers before you reply, before you choose one, which, I think you're going to do fine. So if you're nervous, it's not necessary, okay? All right. Unless there's anything else, I'll let you guys go. And you're very welcome. And thank